Hello everyone, today I'll be showing PCR management, and what I wanted to show is how posterior capsular flap is to be watched and what are the signs that confirm that there is no vitreous disturbance. So now in this video you can see the PCR margins are very well seen. There is some leftover cortex. This was a case of our trainee who had a PCR during IA. Now you can see I am sweeping the iris repositor. There is no movement of the capsule and neither there is any movement of the iris. So that confirms in a way that there is no vitreous disturbance. And now in dry cortical aspiration there is just minimal fluid coming out of the irrigation cannula. Now you can see there is a very small fragment which I aspirated with the help of irrigation and aspiration. So here while I'll be doing aspiration of the cortex, it is very important to inject visco frequently because already there is no vitreous disturbance, and with the help of visco you can push back that vitreous phase. And now while aspirating the cortex, just see how stable the margins of the posterior capsular rent are. They are not moving, and this again is a sign of no vitreous disturbance, because if vitreous would have been there, then with irrigation and aspiration there is some amount of manipulation of the vitreous, and we always see some movement of the posterior capsular flap with irrigation and aspiration. Now this loose cortex is there in the anterior chamber, and then when I injected visco through the main incision, it was expelled out, and now all the cortex was gone, and now we can see the rent margins again very clearly. Visco was injected again to push back that undisturbed hyaloid phase. Iris repositor was again swept into anterior chamber to check for any vitreous disturbance, but as you can see again the rent margins are very stable and there is no movements of the iris. The wound was enlarged with the help of a 5.2 keratome. Since I'll be using a rigid 3-piece IOL in this case, now I'll be inserting a 3-piece rigid IOL. The points you have to take care is that the leading haptic should go just beneath the iris into the sulcus, and when I will be injecting the trailing haptic, the trailing optic part will go beneath the capsular rent margin and that flap will come over the optics. So see, now my trailing optic is beneath the rent margin. Now I am repositing that flap beneath the optics and trying to reposit my IOL. Still the flap is overlapping the optic, and now I injected visco into the anterior chamber, and again I'll be going through side port and will reposit the flap which is over the optic. I'll place that flap behind the optic. I am dialing the IL and I am repositing the haptic, the second haptic, into the sulcus, and the flap I just reposited and it went back behind the optic of the intraocular lens. And now with the help of dialer I will reposit my lens and now you can see the intraocular lens is in the sulcus and it is nicely centered, so one can manipulate gently to center the intraocular lens, and now the IOL is well centered into the sulcus and both the flaps of the rent are behind the lens. After implanting the intraocular lens in sulcus, and since there was no vitreous disturbance, the bottle height was lowered and visco was aspirated from the anterior chamber. Next, I would be injecting pilocarpine. Again, that would confirm that there is no vitreous disturbance, as if you get a peaking somewhere, then probably that will confirm that there is vitreous, but see, the pupil has started constricting and there is no peaking, and so this again confirms that there was no vitreous. And finally, the wound, since we enlarged it, I placed a suture to ensure that wound is appropriately closed, and don't forget to rotate your sutures, as if you don't rotate, that will cause a lot of irritation to your patients. And finally, hydro was done and the case was nicely managed. Thank you for watching this video.